Welcome back to the deep dive. Today, we are taking a scalpel to something that really defines clinical precision. We're talking about the world of malocclusion terminology.
Right.
And this isn't just about, describing crooked teeth. This is a highly detailed, three-dimensional language that dictates everything.
Everything. Diagnosis, treatment strategy, all of it.
Mm.
And it all starts with precision. I mean, the term malocclusion itself needs a clean definition or nothing else that follows really makes sense.
Okay, so what is that core definition?
Fundamentally, it's formative. A condition where there is a deviation from the normal relation of the tooth or teeth to other teeth in the same dental arch, or the teeth in the opposing dental arch.
So a mechanical error in the system.
Exactly. That's a great way to put it.
And what's so great about the terminology in our source material is just how neatly it's organized. Our mission for this deep dive is to follow that logic exactly. We're going to move from the very specific to the foundational. We'll unpack these three major divisions. First, the specific malpositioning of individual teeth.
The single piece.
Then, the relationships between the entire upper and lower dental arches.
The whole engine.
And third, the ultimate determinant, the malrelation of the bony bases, the underlying skeletal structure.
You can think of it as a hierarchy of problems. You start with the smallest component, that single tooth, and you move all the way up to the structure holding all those pieces together.
Perfect. So let's start small then with section A, the individual tooth. If a tooth isn't where it should be, the first question we have to answer is it just leaning out of place? Or has the whole thing, root and crown, physically moved?
And that distinction is the foundation of individual tooth analysis. It's inclination versus displacement.
Inclination versus displacement.
Inclination refers purely to tilting. For the front teeth, if the crown is tilted outward toward the lips, that's labial inclination. We often call that proclination.
With proclination.
Okay, and if the crown is tilted inward toward the tongue, that's lingual inclination or retroclination.
And I'm guessing if we use terms like buccal or palatal, that's for the back teeth. Buccal towards the cheek, palatal to the roof of the mouth.
You got it. But the key insight here is the clinical why. Why do we even care if it's just an inclination?
Right. What's the practical difference?
Because an inclination, a simple tilt, can often be corrected with much lighter forces. Sometimes just clear aligners can do it, since the root apex hasn't really moved much.
But if the whole structure has shifted, that's a completely different story.
A different story entirely. That's displacement, which implies bodily movement.
The whole tooth.
The whole tooth. Labial or buccal displacement means the entire unit root and crown has bodily shifted towards the face. Same for lingual displacement. The whole tooth is moved inward.
You're talking about moving the whole chair, not just leaning back in it.
That's the perfect analogy. And that distinction, it suddenly elevates this from just simple definitions to actual treatment planning.
Because if it's displacement, you're probably looking at full bracket mechanics to drag that entire root structure through the bone.
And that can be much slower, much more complex than just correcting a tilt.
It makes sense.
And this need for precision, it just continues with all our directional terms. We need to know if the tooth shifted toward the middle of the face or away from it.
So we use medial for movement toward the midline.
And distal for movement away from it.
So you could have a medial inclination, the crown is just tilted toward the midline, or medial displacement, where the whole tooth has shifted over.
Correct. And then, of course, the opposite for distal movement. But we also see issues that aren't just about tilt or shift, but about spin. A tooth can be rotated.
And we have to specify that too.
We do. For example, medial lingual rotation means the medial side of the tooth, the side closer to the midline, is turned inward toward the tongue.
And distalingual would be the opposite corner turned in.
Exactly.
That level of rotational precision feels almost excessive. I mean, why is it so necessary? Wouldn't rotated inward be enough?
It all comes back to anchorage and biomechanics. Knowing precisely which corner is rotated tells the clinician exactly where to apply the force to untwist it efficiently without messing up the neighboring teeth.
So it defines the point of attack for your braces or your aligner.
Precisely. The point of attack.
Yeah, beyond the horizontal plane, we've got vertical issues. Too much eruption or not enough.
Right. If a tooth hasn't erupted enough and doesn't reach that line where the teeth meet the plane of occlusion, that's infraocclusion.
And the reverse of that
is superocclusion. The tooth is over-erupted. It's past that occlusal line.
And then there's the real curveball, transposition.
Oh, yeah.
That sounds like a complete mix-up. A tooth just shows up in the wrong spot in the sequence.
Exactly, like an upper canine and a lateral incisor just swapping places. It's rare, but it's structurally a huge deal.
So with all this complexity, how do clinicians manage it?
Well, to simplify things, they often default to Lischer's terminology. What Lischer did was give us the word version to specify the malposition,
So it's like a shorthand.
a very efficient shorthand. Instead of saying the tooth is bodily shifted toward the tongue, you just say lingo version.
Or mesio version if it's too far mesial.
Or labio version if it's too far towards the face. And crucially, Lischer also gave us a term for errors in the root's angle itself, the axial inclination.
What's that called?
We call it axiversion. It means an error in the root's angle, what dentists often call torque. The crown might look perfectly placed, but the root is slanted all wrong in the bone.
Which means the tooth is unstable.
Highly unstable, and it requires very specific, very complex treatment to fix.
Wow, okay, so that really wraps up the individual piece of the puzzle.
That's section A.
So now I zoom out. If section A was about the individual component, section B looks at the whole engine, the relationship between the entire upper and lower dental arches.
And we break this down by the 3 spatial dimensions.
Anteroposterior, transverse, and vertical.
Let's start with anteroposterior, the front-to-back relationship. This is where we find 2 of the most confused terms in all of dentistry.
Overjet and overbite.
Overjet and overbite. People mix them up constantly. Overjet is strictly the anteroposterior measurement. It's the horizontal distance between the frontal lower incisors and the back of the upper incisors.
Horizontal, got it. So if that horizontal distance is too big, the lower jaw can look like it's set back.
Right, which leads to what we call postnormal occlusion. The lower dental arch is too far back, or the upper is too far forward, or pretty often it's a bit of both.
And the reverse of that
is prenormal occlusion. That's often what you see with an underbite, where the whole lower dental arch is ahead of the upper. A related issue here is anterior crossbite.
which is more specific.
Much more specific. That's where just one or more upper front teeth get trapped behind the lower incisors.
Okay, that makes sense. Let's shift to the transverse dimension, side to side.
This is where the width relationship of the arches breaks down. Usually you see posterior crossbites in the back teeth.
So in a standard posterior crossbite, the outer cusps of the upper back teeth are biting inside the lowers.
Correct. The key observation is that the upper arch is just too narrow, or maybe the lower arch is too wide, and it forces that reverse overlap. The lowers are outside the uppers.
And then you have the more extreme version of this.
The more extreme version, yes, it has a few names. Scissor bite, Brody bite, or posterior lingual crossbite.
What happens there?
It's a total mismatch. The lower back teeth are positioned completely inside the upper teeth. The outer cusps of the lowers are biting on the tongue side of the upper teeth.
It sounds like they just slide past each other.
They do. It creates this shearing mechanism, which is why it gets the name scissor bite. It's a really severe transverse problem that almost always needs some kind of expansion or skeletal work. The arches are just totally out of sync.
Okay. And that brings us to our final dimension, vertical.
Which brings us back to that other crucial term, overbite.
If overjet was horizontal.
Overbite is definitively vertical. It's the amount that the lower incisors are covered vertically by the upper incisors when you bite down.
So what if that vertical overlap is missing?
Then you have an open bite. And clinically, we have to distinguish between an anterior open bite, where the front teeth don't meet, and a posterior open bite, where only the back teeth aren't touching.
I imagine a posterior open bite would make chewing pretty difficult.
Oh, it has huge functional consequences.
And the opposite condition, too much overlap.
That's the closed bite, or more commonly a deep bite. The upper incisors cover way too much of the lower incisors, sometimes hiding them completely.
And that causes problems too, right?
Yeah, definitely. It can cause a lot of wear on the teeth and can sometimes even impact jaw joint function.
So we've built this incredible vocabulary for describing every possible relationship between teeth and arches.
We have. But now we have to talk about the root cause that can often override all of these definitions we just went through.
Exactly. We've done the individual tooth, that's A. We've done the arch relationship, that's B. Now for section C, the foundational non-negotiable structure, the malrelation of the bony bases.
This is where we connect all the dots. We connect the shape of the teeth to the underlying skeletal structure, the basal bone.
We're talking about the maxilla, the upper jawbone, and the mandible, the lower jawbone.
These two structures, they determine the starting line for everything else.
So when we talk about skeletal malrelation, we're really talking about growth patterns that decide the final size and position of these bones.
That's it. For example, our source notes the mandible might be intrinsically underdeveloped, a condition we often call mandibular retrognathism. The lower jaw is just naturally set back.
Or the opposite could be true. The maxilla could be overdeveloped, pushing the upper teeth way forward, even if the teeth themselves are perfectly straight within that bone.
In both of those cases, the relationship between the bases is wrong. That leads to what we call a class 2 or class 3 skeletal profile.
Well, why is this skeletal classification so much more important than all the detailed dental descriptions we just spent 10 minutes on?
Because if the problem is purely dental, just teeth out of line and a good bone structure, you can move the teeth. You can address A and B.
Simple enough.
But if the problem is skeletal, moving the teeth alone can't fix it. You're just asking the teeth to compensate for a bone problem.
In other words, if the mandible is just too short, you can try to angle the lower teeth forward, procline them to meet the uppers, but that movement is inherently unstable.
It's unstable because the foundation is wrong.
The bone foundation is wrong.
Precisely. If we see a significant deviation in the size, shape, or position of the basal bone, the critical conclusion is this: the development of normal occlusion is highly improbable without altering the bone itself.
So the skeletal issue dictates the entire treatment plan.
It dictates whether treatment will be tooth movement only, or if it's going to require growth modification in a kid or complex jaw surgery in an adult. At the end of the day, the bone is the boss.
That really frames the importance of everything we just covered.
Right.
We started with the precision needed for a single tooth's position. That was A. Then we followed that map to the full arch relationship. B, carefully separating that horizontal overjet from the vertical overbite.
And we culminated in the foundational knowledge, C, recognizing that the state of the basal bone is the ultimate determinant. It doesn't matter how perfectly you define a tooth rotation if the bone it's sitting in is fundamentally in the wrong place.
It gives you a complete diagnostic hierarchy. So what does this all mean for you as you think about these structures? If the development of normal occlusion is mathematically improbable when the foundational skeletal bases are affected, it raises a huge question for treatment philosophy. Should the main focus be on adapting the teeth to fit a deficient bone structure? Or should the maximum effort be placed early on in changing the foundational bone structure itself? That's the strategic decision that comes from understanding all this complex terminology.